Thank you to everyone who's joined today for our third webinar on the Deficiency Operations Research Committee of Practice. If anyone that is not speaking could phone, that would be wonderful. Thank you so much. Okay, so just a little bit to go over the agenda for today. We will have two speakers today. One speaking about G6PD testing at the point of care and speaking specifically about genetic counseling considerations for the first 20 minutes. Then we'll speak about G6PD deficiency in the Philippines for the next 20 minutes, and we will have time for questions and answers following that. Okay, Gonzalo?
Okay, thank you everybody for making time for this webinar. And we're very, very excited actually to have Dr. Nicole van der Merwe and also Professor Eva Maria Cutiongco-De La Paz from the Philippines. This is actually quite I feel quite strongly that this is an important topic. A lot of the participants on this call are coming to this from the use of the G6PD testing to inform treatment of malaria, but actually it's an underlying genetic condition, and I think we need to think about what the implications are of these test results, and also can we get added value from doing this testing, provide the patient, most critically the patient, added value by making the effort to explain the test results and what the implications are. And I'm very excited that Nicole's bringing her expertise that she's developed in counseling, and particularly in the H3 Africa program, where she's really looking at precisely how to report incidental findings in genetic research. And then Eva will be presenting about the work that the Philippines has done, which actually for several years now we've been seeing, and the Philippines has really been a lead, as you'll see in the kind of networks and supports that they've put in place around genetic counseling behind a very impressive newborn screening program. So without further ado, thank you again to Nicole and Eva for agreeing to participate, and thank you all for calling in for this. And yeah, I'll just pass it on to Nicole. Thank you.
Okay. So we're really pleased to have Dr. Nicole van der Merwe here to speak with us. She is based in Cape Town, South Africa, and currently employed at the Cape Peninsula University of Technology as a study coordinator and at Stellenbosch University as a medical scientist project manager in the Department of Clinical Pathology. She graduated from SU with a PhD in molecular pathology in 2016, and her research has focused on addressing the three main areas of risk in the field of breast cancer genetics. In 2016, she enrolled in the Masters of Science Genetic Counseling program at the University of Cape Town, where she completed her Health Professions Council internship in genetic counseling in January 2019. Her qualitative Masters of Science research focused on exploring local stakeholder views on the return of individual research results and incidental findings obtained with whole exome sequencing. She presently forms part of two H3 Africa-related task forces. One, the Incidental Findings in Genetics Research in Africa expert panel, charged to develop a list of actionable secondary findings, such as G6PD, for feedback in African populations, and has just completed the draft article pertaining to this work. And she is also on the LC task force assigned to develop an ethical framework for feedback of individual findings in African research. She hopes to contribute significantly to progress of genomic medicine in Africa and globally. So with that introduction, please, Nicole.
Good afternoon, everyone. Thank you so much for inviting me to give this presentation. I have to do a little disclaimer. I've never actually counseled for G6PD deficiency. As you know, I'm from South Africa, and it's not something that we ever encounter here in our public or private healthcare system. But yes, through my work with HK Africa, I have come to, read up about it and learn a little bit and have discussions with the African researchers that are actually working with G6PD patients. So yes, I'm not an expert, but hopefully want to give you sort of a general perspective on genetic counseling considerations in relation to G6PD and particularly point of care testing. So just to give you a little bit of background, we all know that it's an essential enzyme in the pentose phosphate pathway. It's also, sorry, did you change the slide there? It's also a housekeeping enzyme that protects our red blood cells against oxidative injury by providing reducing power in the form of NADPH. So whenever we have triggers such as infections like our hepatitis, viral hepatitis, or pneumonia, or even foods such as red wine, flavored beans, soy products, or even medications like anti-malaria or aspirin or antibiotics, it can sort of increase the production of reactive oxygen species, and we need a cellular defense against it. And that cellular defense is called glutathione, and it neutralizes those free radicals by using, by sort of reducing them, and it needs to receive an electron donor from glutathione reductase, and glutathione reductase is heavily dependent on glutathione 6-phosphatase dehydrogenase to actually produce or manufacture that NADPH that then serves as that electron donor. So if there's no NADPH, the glutathione essentially can't neutralize the toxic reactive oxygen species. You can turn the slide, please. So G6PD is encoded by the G6PD gene, which is located on the X chromosome, and it is the gene is actually 18.5 kilobases, and it consists of 13 exons and 12 introns. And to date, more than 185 mutations has been described. So in males, it results in a hemizygous genotype, and in females, a homozygous or a heterozygous genotype. In females, though, heterozygous females, they've got two distinct red blood cell populations. So the G6PD normal red blood cells, as well as the G6PD deficient red blood cells that coexist in the same person. And the proportions of these really just depends on, it depends on different factors, but it is sort of driven by random X chromosome inactivation. So the point of care testing for G6PD is a enzymatic assay, and you wonder, is that really a genetic test? Yes, it is a genetic condition, but you're not testing any DNA. And even though it's a protein assay, the answer is yes, it is still a genetic test, and therefore all the considerations needs to be taken into account. All the normal considerations that you would sort of consider with around genetic testing still needs to be taken into account, even though it's not a DNA test. So a genetic test is defined as any test or procedure performed to identify individuals with or at risk of developing a genetic condition. And this full definition incorporates history-taking, physical examinations, and lab tests. And if you're talking about lab tests, as I said, it can be protein, RNA, or DNA, or chromosomal based. And if you change the slide, please. So yes, the deficiency is a result of a structural defect in the enzyme. And we know to date that G6PD enzymopathy is the most common enzyme defect in the world. It affects more than 4 million people worldwide. And deficiencies can range from slightly reduced activity to extremely low or severely low G6PD activity. And we know that the absence of this enzyme is not compatible with human life because it plays such a pivotal role in energy production in our metabolism and protecting ourselves from oxidative damage. So the World Health Organization has actually divided the levels of deficiency into 5 different classes, ranging from normal enzyme activity or increased activity, which is more than 150% activity with no clinical consequences, to very severe deficiency where you see less than 10% activity. And you can also see chronic and non-spherotic and hemolytic anemia. So what determines the severity of your hemolytic episode can be the dose of the drug or the trigger, the particular variant that the patient has, the age of the patient, and we know that severe reactions are more life-threatening in children, and also pre-existing or coexisting comorbidities. So what are the ethical considerations in susceptibility testing, such as G6PD, or the general considerations? Always hinges on the 4 ethical principles. Whatever we do, whatever kind of testing we implement, needs to sort of be grounded in patient autonomy, which is respecting the values of the patient, justice, which is balancing between the personal needs of the patient and societal resources, beneficence, which is acting to benefit patients by sustaining life and treating illness, and last but not least, non-maleficence is just not doing any harm. And I think particularly with susceptibility testing, we need to, the main ethical considerations are education, patient education and counseling, test interpretation, which can be very complex, the potential for increased monitoring and possible treatment, and what information counts as useful. And those are the things we really need to sort of nail down on when we look at testing for G6PD. So when we look at new tests that are being implemented, they need to sort of meet a certain criteria or qualify, such that they need to address a certain significant morbidity and mortality, okay? And that we know sort of it passes that criteria because we see that it's in sub-Saharan Africa and the Mediterranean parts and Southeast Asia occurs at quite a high frequency. It needs to result in an effective intervention. In this case, we want to make a decision as whether or not to prescribe primaquine, but is there an alternative that is as good? It needs to be highly accurate in identifying individuals at risk. It needs to be reliable. It needs to be relatively cheap. There should be no risk involved or inferred by the testing, and it needs to be acceptable to the population. People must actually want this. So what is the education around this kind of testing? Or how does the population feel about it? Then obviously it needs to have a reasonable turnaround time. You must be able to call back persons to, discuss any changes in treatment, or yes, and it needs to be carried out in a social and ethically acceptable manner. Please turn the page. So when we look at education and counseling specifically in this setting, okay, we're looking at informed consent, which is pivotal when you're doing any form of testing, especially genetic testing. It should be voluntary, okay? The person needs to be able to, after providing consent, they need to be made aware that they are allowed to withdraw at any time, even before disclosure of results. The disclosure of results can be postponed. So if you're doing a point of care test, which presumably will happen within one consultation, and you're counseling the patient there, they are allowed to say, no, but I don't want to know the results now, and you need to make provisions for that. So those are the kind of things you think about. What is your genetic counseling model? Are you going to get the family history and all the relevant information while the patient is sitting in front of you? Then quickly do the test, and when the results are available, discuss it with him then and there, or you're going to make a follow-up appointment. Yes, and obviously, what is the duration of your session? I know with the implementation of point of care, it's aimed at making the testing accessible, but also using the shortest possible time in which to make a diagnosis or identify individuals at risk. So how much time are you allocating for that counseling session? Is it long enough time for the patient to ask all the questions that they need to make an autonomous decision? And obviously you need to cover, before you test, you need to cover the diagnosis. So what is G6PD deficiency? What does this mean? What are the treatment implications? So if we're going to tell you that, you know, you must avoid certain foods and certain medications, is there an effective alternative? Is it accessible? What is the inheritance pattern? We know it's X-linked recessive, so what are the chances of passing this on? If you're an affected male, you will have, all your female children will be carriers, but you won't have any affected sons. If you are in a homozygous deficient female, all your female children will be carriers, but all your male children will be affected. How do they feel about this? How does this impact on their reproductive choices? If they've had maybe an instance where they've had a child with severe hemolysis and they're in and out of hospital, and they, you know, it was diagnosed quite late, that might heavily influence their choice of having another child. What are the options that you're giving them in terms of prenatal options? And these are all things you need to think about before you start offering that kind of testing and engaging in those kind of conversations. Then also, yes, what are the implications for other family members? Because a genetic test result actually is the result of the family. Will they disclose this to their family? Do they want to know? Are you going to send them home with an information leaflet? Are you going to test at-risk family members? What are the social implications? What if you detect non-paternity? What are you going to do then? And also the possibility of psychological stress. As I've mentioned, it might be somebody who's had experience with maybe mild or even maybe severe hemolysis. So how does that impact their decision-making moving forward? And obviously then you'll discuss the test procedure, turnaround time, the accuracy of the results, which will be different. Perhaps if it's a male, which is more clear-cut the result compared to a female, depending on the kind of test that you're using, and obviously the confidentiality of results. Who has access to those results? Is it going into a, you know, like a national database or something? Does medical health schemes have access to that information? Who has access to that? So these are things we need to consider. And then when we look at the test interpretation, so it's one of the greatest challenges in genetic research or clinical genetics, actually. And it requires actually a lot of knowledge about the particular disease you're working with the technology you're using. We need to know what is the error rate of the technology, How accurate is it? What is the sensitivity and the specificity, the positive and the negative predictive value? So the sensitivity is the ability of the test to correctly identify those with the disease, in other words, the true positive rate. Specificity is the ability of the test to correctly identify those without the disease, so it's the true negative rate. And then the positive predictive value, that is the probability that the person with a positive test result actually has the condition. And we obviously have to look at the integrity of the diagnostic chain. And like I've mentioned, there is a difference between testing males and females. In males, it's clear cut because they're hemizygous. If it's positive, you know, they're heterozygote for the mutation, or they can be normal if it's not detected. But in females, it is a little bit trickier to infer with certainty the genotype from the phenotype. But it can still be better to actually do the enzymatic assay. Because in a female with a normal phenotype on the test, that female can actually, on genotype level, be either homozygous or heterozygous. Whereas a female with a deficient phenotype may be genetically either homozygous, deficient, or heterozygous. So you would think that the genotypic classification is better, but it's actually not, because when you find that a female is heterozygous, it will not tell us whether her G6PD activity is in normal range, or whether it's in intermediate, or whether it's in the deficient range. With respect to the G6PD deficiency testing as a preliminary to the administration of hemolytic drugs, the phenotypic classification is more useful because in heterozygotes, the deficient range will be regarded as at risk, just as though they were homozygous, whereas if they are heterozygous in the normal range, it can be regarded as not at risk. So you can get a false negative rate there. Please turn over. So you have to discuss with patients what are the implications of a positive test result. So you need to discuss the increased monitoring that's going to happen. They're not going to be regarded as a normal patient anymore. There might be maybe different treatment requirements. Regular visits, are there provision made for regular or frequent clinical visits depending on the area that you are testing in? Is it going to be subsidized? How is it going to affect the child's schooling? Just things around that, so that they are aware that if a positive result is detected, they're going to be treated a little bit differently. Also, the availability of alternative treatment. If they test positive, they might not be amenable anymore to the most common treatment, or the broad population treatment. Is there an effective alternative? In certain populations, obviously, some cultures will be more affected than others. So it's important to find out what are the myths around being diagnosed with a condition within that population. Maybe they don't want to be labeled as being G6PD deficient if there's this particular cultural sort of taboo around it. Then also there's obviously gender bias because it's X-linked. More males are affected than females. It's possibly worse in males since females have this spectrum, a phenotype that lies on a spectrum from mild to sort of moderate or severe. So males and females do receive preferential treatment. So it's important to also neutralize that gender bias when you're seeing couples maybe, or when you're talking about what kind of children they want to have or what gender children they want to have. So there's those population-specific considerations and there's gender-specific influence such that males in a specific population are at even higher risk, and it's something that needs to be sort of discussed with lots of sensitivity, and they need to know that, you know, they are not that much different. There's nothing wrong with them. It's just that in their population, they've got this, you know, increased susceptibility to hemolysis, and they need to be more careful about the kind of medications they take and the kind of food that they eat. So thinking about what information is useful to provide during a session, obviously the medical and psychosocial effects are very important. And looking at G6PD, it's been associated with so many different conditions. But what do you, so this will depend probably on the family history. And hopefully there will be time, and whoever's going to do the point of care testing will be skilled enough to do it, take a proper family history to see what other conditions are in the family, are they at increased risk, and then with a cumulative risk of maybe having a positive G6PD result, how does that inform the information that you provide to the patient? So it's been associated with ADHD and learning disabilities. If it's a family that already has ADHD running in the family, there's more than one person, how are you going to approach that? There are articles that said that it was associated with later onset of pubic hair development, so that could be a sensitive thing to discuss as well. If you find that in the family history, are you going to link it to the G6PD? Then there's the social stigma around it, and also there's been studies that said that, you know, it confers a protective effect against heart disease, but then others that say that it actually can increase your risk for cardiovascular disease, and then that it's associated with age-associated cardiac hypertrophy and increased vulnerability after an ischemic insult. So if you detect that there's heart disease in the family, what are you going to say around that, and how are you going to approach risk reduction? So it's just a matter of sort of tailoring the session to the patient's needs. Yes, they're there for G6PD, but are there other things in the family history that you could benefit the patient by making them aware that it could be something further to consider? And then because G6PD we know is essential in energy production, there's also a concern about who has, if it's population-based screening, who has access to that data, who has access to the genotypes of the population. For example, employers, if they got hold of that kind of information, can they preferentially employ people based on the perceived efficacy of the candidates? Because if you work hard, you might be more prone to oxidative stress. You might have a greater requirement for regulating or actually your defense. You might need a greater defense against oxidative stress, and if you're deficient, then you won't be able to do that effectively. So it might influence you in many ways. So would employers be able to employ people based on their G6PD status? I don't know. Then obviously looking at the kind of medications that certain populations are advised to steer clear from, or rather consider as alternatives. That obviously should be determined by the treating clinician, but it's important for them to know their G6PD status. And articles have been published on pediatric dental care and in children with G6PD deficiency, such that they advise that actually it's essential to know children's status, because it might inform what kind of antibiotics they prescribe, what kind of anesthesia they will receive, whether it needs to be, whether it can be a local anesthesia or rather general anesthesia in the hospital. So, so yes, many things to sort of take under consideration. Yes, and I'm sure there's a lot more things we can think about, but I just thought to put the sort of just trickle your brains a little bit and just to make you aware of the kind of things we should think around. And I mean, it's important to talk to a medical geneticist or a genetic counselor when embarking on such kind of testing. And I don't know who are the people who are going to be performing the testing. Are they able to address these concerns? Are they able to do the basic requirements like take family histories and sort of frame the results in the context of not only the anti-malaria treatment, but also the patient's family history? Yes, thank you very much.
Thank you so much, Nicole. Okay.
Thank you.
Okay, so next we'll have Eva Maria Cutiongco-De La Paz. She's a professor of pediatrics and genetics and is currently the executive director of the National Institutes of Health, University of the Philippines in Manila. She also heads the section of genetics, Department of Pediatrics, PGH. Dr. Cutiongco-De La Paz is the current president of the Asia Pacific Society of Human Genetics and is a council member of the Human Genome Organization. Her research interests include genetics of monogenic and complex genetic conditions in the Filipino population, such as birth defects, cardiovascular disease, cancer, and diabetes mellitus. And, oh, sorry about that. Okay, thank you, Eva.
Hello, good evening. Thank you for having me for this webinar. I learned a lot from Nicole. So I've been tasked to discuss about G6PD deficiency in the context of the newborn screening program of the Philippines. So let me just give you a brief overview of what the Philippines is so that you can have a better understanding of how we run a national newborn screening program. So the Philippines, next please. Click please. We're in archipelago, covering an area of about 300,000 kilometers squared. And we have about 7,000, actually 614 islands. We're the 12th most populous country in the world and 7th in Asia. And serving 106 million Filipinos now are only 12 geneticists and 14 genetic counselors. Next slide, please. So the newborn screening, yes, please. It's one of the most successful population-based genetic screening program in the Philippines. And it was introduced in 1996 and was integrated into the public health delivery system with the enactment of the Republic Act 9288 in 2004, which is an act promulgating a comprehensive policy and a national system for ensuring newborn screening. Next slide. The act actually has the following components. Can you go back one slide, please? To institutionalize the national newborn screening system. It's an opportunity for every newborn in the Philippines to undergo newborn screening. And actually, all health workers and professionals are obligated to inform parents about newborn screening and include such act in parents' records. Next. Next slide, please. Shortly thereafter, when the program started taking off, a newborn screening reference center was established. And this center really is the one in charge of the program, ensuring that every Filipino newborn has access to newborn screening. In this picture are two of our poster children. Both have congenital hypothyroidism. One was saved, the one who's in orange, and it has now graduated from university. And the one on the wheelchair was not screened from birth and of course remained mentally handicapped, but has been stabilized with intake of thyroid hormones. So they help us in promoting the program. Next slide. Next slide, please. Recently in 5 years ago, we started adding 20 more than 20 disorders from an original 6 disorders. And these additional tests include now hemoglobinopathies, amino acid disorders, organic acid disorders, endocrine biotinidase deficiency, and cystic fibrosis. The original 6 already included G6PD deficiency, and that's together with the G6PD deficiency is congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, phenylketonuria, and maple syrup urine disease. Next slide, please. Next slide, please. So in this picture, you can see those are names. Those black lines are actually names of hospitals and facilities. That's the newborn screening network in our more than 7,000 islands. So it's present in more than 6,000 health facilities in the whole archipelago. Next slide, please. Next slide, please. This is just to show you that one center cannot do the screening themselves or by itself, and we have divided up the country such that there are now 6 existing newborn screening centers that service the different regions of the country. So it depends on your place of birth. Your sample will go to the region, the catchment area, the clusters of that is serviced by one newborn screening center. So there are 6 that exist right now. I'd like to say that this is important to us because we have 2 million babies born every year in the country. Next slide. Hand in hand with these newborn screening centers, we recently set up newborn screening continuity clinics. Realizing also that these things cannot be centralized. All the regions of the country from region 1 to region, you can see here, actually we have about 17 regions in the whole country, and each of these regions will have its own continuity clinic that can be manned by there can be a geneticist, but we're just a few right now in the country, so we're accelerating our program. But we also have started a Master of Science in Genetic Counseling who can partner with even general practitioners or pediatricians in the different parts of the islands. Next slide. As everyone must know, screening is really definitely just the first step in a two-step process. In this diagram, you can see that when a newborn screening sample is obtained from a birthing center, the sample is sent to the newborn screening laboratory for analysis. And if there is a positive result, this will require follow-up testing for confirmatory, and the testing will actually be for the specific disorder. In the next slide, please, you will see the algorithm for G6PD deficiency. So when we get a positive screening result, and the patient turns out to be deficient, there's a follow-up nurse who calls the cases via a one-call policy. If after that the nurse just collates all this information from confirmatory centers and endorses the cases to the continuity clinic. So just to ensure that no patient is lost in the process. Next slide. Next slide, please. So, okay, so this slide shows you that our type of testing as far as the newborn screening is concerned changed. In the beginning, we used the Formazan ring method, and then later on, it was followed by a fluorometric method, which is based on what Nicole talked about on the oxidation of the glucose 6-phosphate enzyme present in the sample, and that the NADP that is reduced to a fluorescent NADPH is measured by a fluorometer. Next slide, please. So after that screening test, the confirmatory test is done. Again, the testing methods have changed over time. From a colorimetric method, we went into enzymatic method, and just recently, we now have a UV kinetic method. So the confirmatory tests are done outside of the newborn screening center. So they're based in hospitals where people can readily access the test to be able to confirm whether a patient is a true positive. Next slide, please. So just to show you the data that we have, we know so far, for the past more than 20 years of our program, we have screened 12 million babies, and about 198,000 are recorded to be true positive for G6PD deficiency, and our computed prevalence is 1 in 61 newborns. About 20% of those will be females. Next slide, please. So we do have issues as far as, can you go back one slide, please? As far as our screening for G6PD is concerned, because not many of the parents bring the children to centers where a confirmatory test can be done. So such that our return rate for confirmatory tests is only about 35%. And we have found out that some pediatricians, because they know about G6PD already, they do not actually recommend the confirmatory testing anymore. Instead, they just advise the parents to avoid the food and drugs that are found in the list that we give for G6PD deficient patients, which of course is not going to give us the true accurate figure of incidence for our country. Next slide. So genetic education starts with actually when we do counseling in 2 ways. First, it can be on a one-on-one consult. So the parents bring children to a private practitioner where they can have their own a geneticist who can do the counseling. But there is another way, and that parents and families receive education and genetic education and counseling, and that's through seminars that we conduct. I will talk about that later. So for the genetic education part, we do talk about the pathophysiology, pretty much what Nicole discussed earlier, about how G6PD happens, and the manner that they are screened, and how we do the confirmation. So these are discussed during the counseling session. And as far as the management is concerned, we emphasize to the parents that there is no cure for G6PD deficiency, and that the main goal of the management is really avoidance of oxidative insults, and blood transfusions only happen for acute hemolytic crisis. If they actually need further advice, we refer them to pediatric hematologists. Apart from the management issue, we talk about prognosis, and we just really assure them that most of our G6PD deficient patients in the Filipino population live normal lives, and that we just really advise them to avoid the food and drugs that we give to them. Just a word about the confirmatory tests done. It does not really allow us to differentiate mild, moderate, severe, such that we give the same advice to patients, whatever the value of their enzyme assay reveals to us. Next slide, please. So for the counseling part, go ahead. You can. Okay, so again, just like what Nicole emphasized, we talk to parents and families about the condition being inherited in an X-linked recessive manner, and that it's more common among males. Females are carriers and are usually unaffected, but we do get females who can be affected, as I mentioned. About 20% of our patients who are confirmed cases are females, and we explain to them that it may be that they have a mutation in both copies of the G6PD gene. But for those females who may just have one mutation, they may actually have lower G6PD activity than would normally be expected due to skewed X inactivation. We do discuss this during the counseling part. And if a mother is a carrier of an X-linked recessive condition and the father is not, the risk to each child depends on whether the child is male or female, such that if the child is male, the risk that the child can be affected is 50% and 50% not affected. And for female child, it's a 50% chance of being not affected, not carrier, and 50% not affected but carrier. Next slide, please. We use a lot of these materials for counseling part. We found that there's no better way to explain all this inheritance pattern than to have these figures that show how the gene may be inherited. Next slide, please. We have developed facts sheets. These are information for doctors about disorders included in our newborn screening panel. And in this particular page, you see for glucose 6-phosphate dehydrogenase deficiency, it discusses pathophysiology, the clinical features, and more importantly, on the right are the food, drugs, and chemicals to be avoided, which is actually in the next slide. Can we go to the next slide, please? Okay, so here is the list of foods, drinks, and chemicals to be avoided in G6PD deficiency. You can see that it is grouped in 5 different ways. The first is drugs to be avoided at all times. And then the second group are chemicals to be avoided, which even includes like dyes and methylene blue. And the third group will be food and drinks to be avoided, like the faba beans, soya. We have a huge Filipino-Chinese community, and this can be really something that makes a lot of families sad because many of the Chinese have soya-based food. The fourth group at iba pa means etc. So this includes like even menthol and efficacent oil, and as well as Listerine and painkillers. Also naphthalene balls like mothballs are to be avoided. The fifth group will be drugs that are safe to take in therapeutic doses. So you have there even paracetamol and ascorbic acid, but we just advise them that if they're taken at the dose that the physician, that pediatricians give, they shouldn't have any problems. Next slide, please. Because we really have lots of patients that turn out to have positive cases for G6PD, we started seminars, doing these G6PD seminars for parents, and conducted by Department of Health regional offices together with our newborn screening centers and continuity clinics. The seminars are either standalone fora or are integrated with other activities, such as we do conduct what we call reunion of saved babies. So they attend those seminars, and during those half-day seminars, these are the things that are discussed. What is G6PD deficiency, the genetics of it, its prevalence, the clinical manifestations, signs and symptoms, especially of hemolytic crisis, precipitating factors, treatment, food and drugs to be avoided, important reminders, signs and symptoms, and also to address queries from parents. Next slide, please. So these are just the many pictures of the many seminars that we conduct. You can see that we geneticists really play an active role in these seminars to give mass, quote-unquote, genetic counseling. Next slide, please. Now we have, you can see here, the term GIDA. For patients in GIDA means geographically isolated and disadvantaged areas. We have recently set up Tele-Genetics referral system, and we will increasingly utilize this as more areas in the Philippines, in the archipelago, gets access to internet. Next slide, please. But sorry, just to mention that for the telegenetics, it's not only for G6PD deficiency, but for all other cases that we see. Here in this slide, you see some of the resources for parents that we also develop. And we have brochures not only in English, but also in our local in our dialect, which is Filipino. Next slide. So what I wanted to just to wrap up this presentation is that we still do face a lot of challenge in terms of, as I said, one, that we are unable to classify the patients, whether they're mild, moderate, severe, and so we just give the counseling is similar to all the patients until such time that we develop second-tier testing. We do have some preliminary data already using DNA molecular testing for common mutations in our population. And if we develop such kit, then and do some phenotype-genotype correlations, then we should be able to give better information to our parents and families and advise them better as to what the particular severity of the G6PD they have. And the third that we are still trying our best to develop is really to put the food in the Filipino community context to make sure that the food in our list really they really cause they can cause the hemolytic crisis. So we have some groups working on that as well. So with that, thank you for your attention, and I hope that I have contributed to this webinar.
Thank you so much, Eva. It's now time for questions and answers. So please, I think we have about 10 minutes, and so would love to get your questions now.
So maybe I'll open it up. Again, thank you, Nicole and Eva, and then please, others, feel free to ask questions at this point in time. Maybe a question to both of you from very different perspectives. Do you think there should be different considerations around counseling based on whether someone has been diagnosed as part of a malaria treatment algorithm or as part of newborn screening?
Can I answer first? I think I know that Nicole talked about as a general standard rule, we should be doing pre-genetic testing counseling, and that's what she described as far as a point of care testing is concerned. Am I correct, Nicole? But I think in the context of newborn screening, that is going to be quite difficult for us to implement. We do give information brochures prior to any, there's information that's passed on by the health provider about newborn screening, and we only actually do genetic counseling once they are confirmed. So I think it takes a different context if it's part of a population-based screening versus point of care testing.
Okay, thank you. That's helpful. Nicole, any comments? I realized that you may have to drop off sooner.
Yes, so if I understand your question correctly, is whether there'll be different counseling considerations with newborn screening compared to population screening.
Yes, and Eva just kindly pointed out that the challenges of, for example, the specifically pre-counseling, but even in context more generically of counseling. Yeah.
Yeah, so I think with newborn screening, there's potentially going to be a lot more counseling considerations, because you have the counseling session for one is going to be a more sensitive, a more involved and detailed session, because you have a child that is going to lead their entire lives with the knowledge, of this diagnosis. So talking to the parents about how that will affect them later in life and so on. And compared to when you're counseling adults and doing point of care, when you're in a session, maybe in a setup, maybe where it's done as a routine point of care test, and it's you might not have such so much time, or not a lot, have a sort of comprehensive counseling session before, but just post-test counseling. So yes, I mean, in general, there are different considerations when it comes to counseling in the setting of children compared to adults, and that could influence not only the amount of time and the level of experience of the people that are doing the counseling. I mean, we live in countries where we do not have enough genetic counselors or medical geneticists, but training of health nurses, training of other people, if it's going to become a population screen, is going to become an important consideration. Thank you.
So that leads very nicely into a question. There's a question from Jane Cunningham from WHO, and also a question from Cindy Chu from SMRU. And but your last comment led very nicely into a question that she's asking, which is who normally provides the genetic counselling? And in your both Nicole and Eva experience, do you think a health worker or a village health worker who would be the people running these tests for malaria case management be responsible? Can they be responsible for basic genetic counselling? And your thoughts on that would be helpful, and maybe also other people from this call should chime in. But first, Eva and Nicole.
Can I? So.
Yeah.
I definitely think that we need to not only upskill, but we also need to upscale. And so we need to use, our general nurses, and we need to use the people that are available, that are already working with patients, because they really have that psychosocial, if I can call it, advantage. And speaking specifically about nurses, they know how to deal with people. All they need is then a little bit more training on the genetics, and usually they are the people that can relate more to the patient, so they know the language and the cultural nuances of the patient. So if they can just be trained a little bit on the genetics, I think they can definitely do the basic counseling. And what we've started implementing are these eco online monthly oncology meetings where we actually have different spokes ranging from, it's a multidisciplinary team where we could actually include nurses and field workers or other healthcare workers and you know, walk a road with them and see how they're actually doing, help them to address complex cases and just sort of yeah, give them input as they are the ones that are actually dealing and counseling with patients.
Thank you. Eva, do you have comments with regards to, because it's very interesting, you're talking about the Tele-Gen network and that, and I guess how do you find that interface? How do you see that interfacing with the people on the ground in those more remote settings where you're expanding the newborn screening program
Okay.
to?
When I started my presentation, I gave you an overview of, like, we have like almost 106 million Filipinos. We only have 12 geneticists, and actually in the beginning, we were only 2 geneticists. At the time, the population of the Philippines was 75 million. And then Dr. Padilla and I started a fellowship training program. So we've trained people and they also come from the different island groups so that we can populate those islands with some more geneticists. But we also still felt that we were not enough. And that's why a Master of Science in Genetic Counseling program was started, and we graduated 14. But then again, 26 people will still not be enough to serve the whole country. And that's why we have been conducting seminars now for nurses and even general practitioners or pediatricians, teaching them about genetics and genetic counseling so they can do it themselves. So I think human resource is really going to be a problem in implementing big programs, but we can have ways to address it by engaging, like as mentioned here, even healthcare, you know, the people, healthcare workers who can be trained to give basic genetic counseling. We are for that.
Thank you. I guess one question that Jane has kindly raised is, and you alluded to this in your discussion of the algorithm for treatment. One of the challenges is that these tests are going to be given at the point of care, and the likelihood that a confirmatory testing it's going to happen is low in many countries where actually they don't have the kind of robust platform that the Philippines has established. You can imagine being able to leverage the newborn screening platform to do confirmatory testing where point of care testing is happening. What are your thoughts in terms of managing that and actually providing that counts? How would you manage the fact that there might not be confirmatory testing and in context of counseling? And Jane, jump in if I got your question.
Hi, I'm not sure if you can hear me.
Yes, we can.
Oh, you can. Okay, no, thanks, Gonzalo. I think you've pretty much got it. I guess what the question that I'm asking is saying, given that we know this confirmatory testing is probably not going to happen in most cases, you know, it's clear we can use that information to guide whether or not this patient, you know, what drug and what regimen or whatever they receive for malaria treatment. But I guess I'm wondering, as a geneticist, you know, what is the best option there? If we know we can't confirm those results, if we know that prevalence still in the population is quite low. Therefore, the positive predictive value of the test may also be quite low. Is it good enough to give a definitive diagnosis of G6PD deficiency and, and then do all the additional counseling? Or should we really just be using it to guide malaria treatment and testing patients each time, they come? Because, realistically, we don't think that confirmatory testing is going to be available. And I just wonder about the ethics of it, right? If you can't do confirmatory testing, is it right, given all of the additional, potential consequences of having this diagnosis, to assign that unless you're really sure?
So I thank you for your question. I mentioned earlier that we actually set up a lot of confirmatory centers in the country. And these people who turn out to be positive, the follow-up nurses call them for them to come in. It's just that one of our challenges is really people not really wanting to come in because they don't see that there's anything wrong with their child, right? And the pediatrician's not encouraging them. So it's not a matter of not having the confirmatory test. It's more like people actually coming in for the confirmatory test. So we want, of course, to be able to confirm whether they're the true positives, because we give them that information of drugs and food to avoid, which is also something that we also advise them to give this information to their doctors, that their child has been confirmed to be G6PD deficient. So that's pretty much how it works right now. The confirmatory test is available. They just really have to come in. It's not very expensive. And so at some later point in time, some point in their lives, in these children's lives, should they need anti-malarial drugs, then the fact that they have been confirmed to be G6PD deficient should already lead, direct the treatment for their doctors. I don't know if I answered your question correctly, but
well,
as I said.
No. In part, I guess what I'm wondering about is, as you say, it is available in the Philippines. It's more an issue of people not following up, which is a bit different than, say, in Laos or Cambodia or, Myanmar, where that confirmatory testing, if it is available, maybe it's in one hospital in the country. So that's why I'm just wondering, what is the most sort of ethical, way forward, where you just know that the best you're going to get is a screening test?
Yeah, I think that really raises a big ethical question, because one of the tenets of newborn screening is you want to test because you can do something about it, right? So if they will not be the confirmatory test is not available, then I guess it should be offered in the context of not of a screening program, but more of at the point of care testing. That's the only way you can balance off the ethical issue of it.
Yeah, is that you essentially use it. We use it for the immediate purpose, which is to guide a clinical decision making, but we don't then assign this definitive lifelong diagnosis on the basis of that. Okay, that's helpful to have that
agree with you. Yeah.
Okay, well, thank you, Eva, and I know Nicole had to step off, but thank you everybody for attending the call, and thank you so much, Eva and Nicole, for these two great presentations. And as I mentioned, it's always very impressive how thoughtful the Philippines has been about this whole process. Anybody want to chime in just before we close up?
Just want to tell everyone that We will be following up with the slides and a recording of the webinar by the end of next week, and we will also have a couple new resources to share. So we'll be reaching out to you. So check over your emails. Thank you.
Thank you too for allowing us to share with you our experience in the newborn screening program, in particular about the G6PD deficiency.
Thank you so much.
Thank you.
Okay,
Great work that you're doing.
thank you. Bye-bye.